So let us start with the final phase, though this doesn't cover full of strabismus, but a major part is covered, and this will be little bit brief, a brief description of all the different other types of strabismus, which we call as um, special forms of strabismus. Let us start with paralytic. Again, in paralytic, we have the actual nucleus, the nerve paralysis, which is the third, fourth, and sixth nerve. And it can be a supranuclear paralysis, which is monocular elevation deficiency, Mobius, and gaze palsy. So, few things what we do need to know about paralytic strabismus is about its characteristics. First is incomitance. By incomitance, it means there is when the in at different gazes the angle of the squint is different. Okay, that is called incomitant. Comitant strabismus, on the other hand, is mostly on all gazes the measurement is more or less the same. One or more of the muscles will be paralyzed. That is the limitation of movement. So now, depending on which nerve is paralyzed, we can expect the limitation of movement. And the when we do a clinical examination and cover test, there is a difference in primary and secondary deviation. Now, what is primary deviation? Primary deviation is when we are measuring with, suppose we are doing a modified Krimsky or a cover test in which the patient is fixing with the paralyzed eye and with the non-paralyzed eye. So the measurements in both the conditions will be different. So that is called the difference in primary. The stages of paralytic squint are of the muscle, then we get overaction. Suppose, is the voice clear?
Voice is breaking,
Yes,
sir.
it's absolutely clear.
1 minute, let me see. Hi, is it clear now?
Yes, sir.
Okay.
Yes, very clear.
Hmm. And there is there is overaction of the same eye. Suppose the lateral rectus of right eye is paralyzed, then there will be overaction of medial rectus of the right eye itself, and underaction of the antagonist contralateral synergies. What do you mean by that? Opposite eye same, like if the lateral rectus is paralyzed this side, the opposite eye lateral rectus. And now let us come with individual nerve palsies. First it will be first we'll go through the third nerve palsy. What are the signs what we see in third nerve palsy? First, most if it is a total third nerve palsy, then it will have ptosis, and except lateral rectus all the and superior oblique, all the extraocular muscles are paralyzed. So you will expect a medial movement limitation, and again a superior movement limitation, inferior movement limitation. The superior oblique is acting, but it is difficult to analyze the superior oblique in these cases. That can be done by checking for intorsion. If intorsion is there, then superior oblique is there, movement is there. Now, there is a phenomena called pupil sparing third nerve palsy, and sometimes even ptosis may be absent in these cases. But if the pupil is spared, what do we expect? So that is one of the good signs, because that occurs due to microangiopathy, especially seen in diabetes or hypertension. So, if it is a pupil sparing third nerve palsy, we need not investigate too much. A blood sugar control and close observation, and generally it heals by itself. And suppose it is not healing within 2 to 3 weeks or 1 month, then we may go for neuroimaging.
मेरा चश्मा
Now, next is superior oblique palsy. Lateral rectus is obvious, so I'm not
मेरा
covering lateral
चश्मा
rectus, but mic can be switched off, please. Uh,
Dr. Lal, you can unmute
yeah,
your mic now.
yes. So, in superior oblique palsy, first, the most important, the most of them are congenital, but they present in probably the fourth or fifth decade of life. Most of and throughout the life, the patient has been managing with some head posture, and it doesn't get diagnosed till the fourth decade, and then suddenly the patient develops diplopia. When once they go to presbyopic age, and beyond that, they develop diplopia. So, due to the face posture, the head posture that the patient has been maintaining, you will notice a facial asymmetry in these patients, because they always maintain one posture that leads to some asymmetry in the face. So that has to be very carefully looked for, and history will be typical, like the double vision occurs mainly when looking down, because superior oblique is down and medial. So looking down, and most commonly they tell that while going down the stairs and while reading. So these two situations, the double vision increases. So what has to be done for that? That I'll come in the treatment part. And when we do the examination, I'm just covering the salient points of all these conditions. These are the most important points. These are not very comprehensive, the most important ones. The association is with or without inferior oblique overaction. This is again important, because based on this, our surgical plan may change. And most of these patients, and among the paralytic squint in adult, fourth nerve is one of the commonest. How do we diagnose it? Diagnosis is with the, as we had discussed earlier, the Park's 3-step test. So we do the measurement in primary: right gaze, left gaze, right head tilt, left head tilt, and then match it with the table for paralytic vertical squints. And treatment is, most of the cases, the double vision goes with a small prism, because the angle of squint in superior oblique palsy is generally less than 10 prisms vertical squint. So that can be neutralized with prisms in both the eyes. And in, if it is not being done, and if that is not helping, then surgery may be required. And in surgery, the decision is based on two factors. One is inferior oblique, whether it is overacting or not, and second is whether there is laxity of the superior oblique tendon, that we get to know from the FDT, what we do on the table. So if it is lax, if it is, there is too much of, we are able to intort it a bit too much or extort it a bit too much, then in that case the tendon is lax. So either a superior oblique tendon tuck procedure is done, or inferior oblique recession is done if there is inferior oblique overaction. If it is not there, then inferior oblique need not be touched.
लव कोच गवे का म्यूट हो गया.
Dr. Love, your mic is please unmute
Huh.
your mic.
Yeah, it's clear now. So can you hear?
Last 2 minute session you can repeat, sir. The voice was not there.
In this, I'll go to the previous slide then. So this slide was there. The voice was there in this slide.
Yes. Voice was clear in this slide.
Okay. So next we'll go to when we have a paralytic squint, we do a diplopia charting, and this is a rough representation of how do we chart the diplopia and the Hess chart. In Hess chart, in this, as you can see, there is a left lateral rectus palsy. So when we are doing the movement for there is restricted movement of, and we don't use the word restricted whenever we are describing a squint. Limitation of movement. Restriction we can use only after force duction test. So before force duction test, what we have to write is limitation. So left lateral rectus limitation is there, and at the same time the right medial rectus is overacting. So that is denoted by these long arrows in on the Hess chart. Now this is a Hess chart of right superior oblique palsy. If you can see here, the medial and down movement is with right superior oblique, and that is underacting, and the same eye inferior oblique is overacting. So in this case, we can plan for a inferior oblique recession. Same thing for a left third nerve palsy. Now you can see the left eye, only the lateral rectus is acting and all other movements are gone. So it's not there. And in the contralateral, the right eye, the lateral rectus of right eye is overacting. So that is how we document a paralytic squint. Now coming to next, which is common, this is one of the common squints what we see in our day-to-day life, and these are Duane's retraction syndrome. So as it is clear with the name, two things are there. One is limitation of whichever eye is affected, limitation of movement can be there, most commonly the lateral movement limitation. And apart from that, there is a variety in which there is a medial movement limitation, and another third variety in which both the lateral and medial limitation is restricted. And when you attempt a medial movement of the same eye, there is retraction of the globe. So retraction of the globe or narrowing of the lid fissure on attempted adduction, and very common in this is upshoot and downshoot of the affected eye on adduction, that can be there. And in 1 to 5% incidence is there, and there are various theories, one of them being agenesis of the sixth nerve nucleus and paradoxical innervation of the lateral rectus. As you can see, in primary gaze, in this child, in primary gaze there is left esotropia, and in lateral gaze the left eye is not moving. In medial gaze there is retraction of the globe. So this is type 1 of Duane's with a abnormal head posture. This is a typical candidate who should undergo surgery if presenting with Duane's, because in primary gaze there is esotropia and head posture. And what surgery will be done? Recession. Left eye we cannot do resection. So left eye lateral rectus resection is totally ruled out. So what we will do is a left medial rectus recession, and if the angle is large, which it seems in this eye, even the other eye medial rectus recession can be done. Type 2, as I told, the abduction, the lateral movement is normal, but the medial is limited. But 95%, I would say 99% of Duane's are type 1. You very rarely get type 2 and type 3. Type 3 is both the medial and lateral movement is limited. So left eye, you can see here, left eye lateral movement is limited, and left eye medial is also limited, and there is upshoot when he is attempting adduction. So that is type 3. Then this we have discussed earlier. Strabismus fixus again comes with presents with a very high myopia, and there is a large angle esotropia with limitation of movement, and this is also called heavy eye syndrome. Because of the large eyeball and limited movement space in the socket, it leads to esotropia. So what do we do in such cases? And generally it is these eyes are not amblyopic because it occurs with time. So in this we can do either a medial rectus supramaximal recession, or very if it is a, sometimes if this eyeball is going even inside, we can do medial rectus recession and lateral rectus resection, and medial rectus will always be supramaximal. Next would be Brown syndrome. All these we have discussed in the last few days, so it's a revision of that. And most important, if you are getting inferior oblique paralysis, it mimics inferior oblique paralysis. We should be clear about that. Whenever there is limitation of movement in the superior and adduction and superior, then it is most likely a Brown syndrome. It is not a inferior oblique palsy, because isolated inferior oblique palsy is not that common. And there can be acquired Brown syndrome also, mainly if there is some kind of injury, and then that may lead to a acquired Brown syndrome. So treatment wise, what do we do? If it is in primary gaze, if it is ortho, then there no treatment is required. But if there in primary gaze there is a vertical squint, then surgery needs to be done. Another condition, this if you are practicing pediatric ophthal, this you keep on seeing, and that is called congenital fibrosis of extraocular muscles. It generally runs in the family, and we had I was trying to find that photograph. We had a family in which two generations had a father had, and two children had congenital fibrosis of extraocular movement or extraocular muscle. So in this, what happens? There is restriction, there is limitation of movement in all directions of the gaze. And worst part is that it is progressive. Slowly the eyes become almost fixed. And there's not much we can offer as treatment of this condition. Thyroid ophthalmoplegia, all of you know, if there is a hyperthyroid condition for quite long, then the most common muscle is affected is inferior rectus. So along with if inferior rectus, if it gets fibrosed, then it pulls the eye down. So it is a restrictive pathology, and that will be confirmed on force reduction test. And most of the times it is associated with proptosis, and depending on how the condition is, the most important treatment will be thyroid. Sometimes we thyroid control, and sometimes we give for acute conditions of thyroid ophthalmoplegia, sometimes steroids are given. But once the proptosis has set in, the chances of the eye going back to normal size is not there, and has to be treated with lubricants and vertical muscle surgery, most common being the inferior rectus recession. And in this, approaching the inferior rectus becomes very difficult because it is fibrosed and has pulled the eye down, so we don't get too much of access, in which case the double armed hook is used for suturing the muscle, as I had shown in the video yesterday. Adherence syndrome, again, all these are common conditions. It is whatever I'm mentioning, it is not that we don't see in clinic. We see on regular basis these conditions in our clinic. And adherence syndrome may be due to a trauma which has led to injury of the extraocular muscle and adhesion of the conjunctiva with the extraocular muscle. That may lead to restrictive squint and extraocular movement limitation also. And earlier, when scleral buckle was the most common form of retinal detachment surgery, this was very, very common. And even now, we keep getting post RD surgery. Patient coming, and if the vision has improved, then patient gets diplopia, and they come to us for squint evaluation. So, if the diplopia is constant and not getting corrected with the prism in the spectacles, then we may have to go for surgery. And most important is the incision has to be fornix based. That means the incision has to be at the limbus, and then slowly we keep on dissecting the planes and till we get the extraocular muscle. And we have to be careful if there is a buckle, and can be combined with a buckle removal surgery also. Mobius syndrome, till date I have seen one patient of Mobius syndrome which is bilateral 6th and 7th nerve palsy. That means bilateral lateral rectus palsy leading to uh, esotropia. And how do you diagnose bilateral lateral rectus palsy? Again, you have to cover one eye and then see the extraocular movement of the other eye. So when both eyes have to be tested separately, and absolutely expressionless face because of bilateral 7th nerve palsy. And then apart from 6th and 7th, the higher the brain stem cranial nerves are also involved. That means 8th, 9th, 10th, 11th, 12th, all that has to be tested. All the cranial nerves have to be tested, and you have to do neuroimaging in these patients. These patients, definitely neuroimaging is required, and if something comes, then you have to refer to a pediatric neurologist. Skew deviation again is a seesaw presentation. Suppose the right eye is up, left when right eye goes up, the left eye goes down, and vice versa. And generally, it is associated with rotatory nystagmus also. Again, in these cases, neuroimaging is required because it may be due to a brainstem or cerebellar lesion. This is one of the common presentations, which is double elevator palsy, or it is also called monoocular elevation deficiency. And what happens in this? Both the elevators, namely the superior rectus and inferior oblique, is affected, and it also has ptosis because again third nerve one division supplies the superior rectus and one to the levator, so has ptosis also. In these cases, how do we evaluate? Apart from the squint evaluation, force reduction is must before planning any surgery, because a prolonged paralysis of superior rectus and inferior oblique may uh, lead to inferior rectus fibrosis as well, because inferior rectus is always in a contracted state. So eventually that leads to fibrosis. So when you do the force reduction, there is no free movement of upward movement of the eye. That means that gives confirms the diagnosis of inferior rectus restriction. And in these cases, first we have to correct the squint, because part of the ptosis gets corrected only with squint correction. So after squint correction, if there is ptosis, then we plan for a ptosis surgery. And there can be a supranuclear gaze palsy. Again, in this there is a paralysis of binocular gaze. Both the sides, both eye lateral gaze may be affected, or both eye medial gaze may be affected, or one of the up gazes. And again, this is due to central nervous system problem and has to be neuroimaged. And when any squint is not fitting in any category, think about this. That is myasthenia gravis. And especially when there is sudden onset, then double vision, the measurements are not very clear. Like we are not getting same measurement in every visit. And I'll just give you an anecdote here. Recently, just 2 months back, one of the senior pediatricians in Calcutta came to me that he's having double vision, and there was no lateral rectus palsy, but there was exotropia. Sometimes the angle was 40, sometimes it is coming to 20. And he himself, being a practicing doctor, was very upset because that was affecting his day-to-day activity. So I just told him to meet a neurologist and get a myasthenia test done. And he came to be myasthenia positive. And as myasthenia was treated, the eyes came back to normal position, became parallel. And myasthenia, one of the common presentation is ptosis, and very if ptosis is there, then you can do a ice pack test and put a ice pack over the eyes and just see whether ptosis improves or not. That confirms the clinical diagnosis, but the blood test has to be done, which is anticholinesterase enzyme inhibitor test. So if that comes to positive, then that is a confirmative. That more or less in brief covers the other types of strabismus. And before we go for vision therapy discussion,